Hi and welcome to this video on Hodgkin's lymphoma. For a brief overview, I'll be giving you some background information about the condition before moving on to pathophysiology, the clinical presentation, key investigations, as well as the management for Hodgkin's lymphoma, before giving you a very brief discussion on prognosis. First, Hodgkin's lymphoma is a malignant lymphoma arising from B lymphocytes, and it's actually the most common lymphoma in young adults in the UK, particularly in the 15 to 34 age group. It accounts for around 1,800 new cases per year, which makes it relatively rare compared to conditions like non-Hodgkin's lymphoma, but its age distribution makes it clinically important. The one fact that examiners absolutely love is the bimodal age distribution. There's a peak in young adults between 20 and 40, and then a second peak in those over 55. So if you see a young person with painless lymphadenopathy and B symptoms, Hodgkin's should be high in your differential. In terms of risk factors, EBV is the most well-established association, particularly with the mixed cellularity type. Immunosuppression also increases risk, which is why you see higher rates in HIV-positive patients. And a first-degree family member with a history of Hodgkin's lymphoma or other malignancy also confers increased risk. One extra point worth knowing: Hodgkin's lymphoma is slightly more common in males, and overall it has an excellent prognosis with a 5-year survival rate above 85%, which is something we'll come back to when we discuss management. So let's talk about what actually is going on in Hodgkin's lymphoma at a cellular level to help you better understand how the symptoms and the investigations, as well as the management, all link together. It all starts with a malignant transformation of a B lymphocyte. Something goes wrong genetically, and instead of the cell behaving normally, it loses the ability to undergo apoptosis, which is the normal programmed cell death that keeps your immune system in check. And because these cells can't die off like they should, they accumulate. These are what we call Reed-Sternberg cells, large binucleate cells with those classic owl eye nuclei, and they're pathognomonic for classical Hodgkin's lymphoma. Importantly, they are CD15 and 30 positive, but CD20 negative. Again, something that could come up in exams. Now, this is where symptoms come from. The Reed-Sternberg cells aren't just sitting there, they're releasing cytokines, particularly interleukins 5 and 13, and that drives a massive inflammatory response around them, and it's that which causes systemic inflammatory response, which results in us having B symptoms, the fevers, the drenching night sweats, and weight loss. Now, in terms of subtypes, classical Hodgkin's lymphoma has 4. The most common by far is nodular sclerosis, which accounts for around 70% of cases, and is the one you typically see in young women with a mediastinal mass. Mixed cellularity makes up around 25% and has the strongest association with the Epstein-Barr virus. Then you have lymphocyte-rich and lymphocyte-depleted, both rare, but it's important to note that the lymphocyte-depleted one is associated with the poorest prognosis and has a strong association with HIV. Now, looking at the clinical presentation for Hodgkin's lymphoma, first we have painless lymphadenopathy, with cervical being the most common that people find. Other lymphadenopathies include mediastinal, axillary, and inguinal. And what's important to note is that they are rubbery, firm, non-tender nodes. Some other features you can expect are splenomegaly, pruritus or itching, and a pathognomonic feature is alcohol-induced lymph node pain. Oftentimes, questions will hint that a young person went on a night out and had a painful swelling in the neck afterwards, hinting at potential of Hodgkin's lymphoma. Some of the B symptoms to consider are fevers of over 38 degrees, drenched night sweats, as well as unexplained weight loss. In terms of investigations, we can first start with blood tests. So a full blood count will show you anemia of chronic disease and potentially eosinophilia. You can also have elevated inflammatory markers and LDH, which is one of the markers of tumor burden. And you can also have increase in ALP, but that is typically seen if there's bone or liver involvement. Now, it is important to note that the gold standard investigation is a lymph node excision. We will see Reed-Sternberg cells, and it is important that it's an excision, not a needle biopsy, to assess the full architecture of the lymph node itself. Some of the other investigations we would do are CT chest, abdomen, pelvis to assess for the extent of the disease and allow us to complete the staging, as well as a PET CT scan, which is the gold standard for staging and is often used after initial cycles to guide treatment. Some of the things we utilize as well is the Ann Arbor classification of lymphoma, which I would encourage you to look up, as it's not something we'll be going into detail in this video, but it can help you determine the staging of the disease based on what the imaging itself has found. Some other investigations to consider are echocardiograms and pulmonary function tests, and that's because some of the chemotherapy used in lymphoma can damage both your lungs and your heart. So let's move on to management, and this is where the good news is. Hodgkin's lymphoma is a treatable cancer. For early stage disease, stages 1 to 2A, the standard approach is ABVD chemotherapy and at times also radiotherapy. Now, in advanced stages, we would increase the amount of ABVD and we would also have additional scans to ensure that the treatment is appropriate. Now, for relapsed or refractory disease, there are some PD-1 inhibitors, stem cell transplants, as well as salvage chemotherapy that can be utilized. And we can also talk about some of the complications of treatment. So in bleomycin, we can see a lot of pulmonary toxicity. In doxorubicin, we can see cardiotoxicity. And in radiotherapy, we obviously can have secondary malignancies as well as hypothyroidism. It's important to counsel your patients on infertility before starting them on treatment, as this might be something that is very important to them depending on the stage of their lives that they are in. Prognosis for Hodgkin's lymphoma overall is excellent. It's one of the most curable cancers. Their 5-year survival rate, even for stage 4, is over 80%. Some of the late effects of the treatment to consider, as previously mentioned, are the secondary malignancies, particularly breast cancer, lung cancer, cardiovascular disease, hypothyroidism, and bleomycin-induced pulmonary toxicity. Infertility is important, as previously mentioned on the management slide, so discussing sperm or egg banking before starting chemo is also crucial. That was a very brief overview of Hodgkin's lymphoma. If you have any questions, please leave them down in the comments. Please like and subscribe and let me know what other videos you would like to see next for the MLA AKT exam.